Colleagues to Home Nursing Foundation's CME webinar series. And today's topic is on critical appraisal of medical research. And we are very, very pleased to have with us Dr. Tiah, who is currently physically at the borders of Thailand and Myanmar, to bring to us this topic. Home Nursing Foundation is the largest home healthcare charity in Singapore, and we have been providing home-based medical, nursing, therapy, and home personal care to more than 5,000 frail and vulnerable patients each year. We also run 2 senior care and community rehab centers at Hougang and Buangkok, and also active aging centers to serve the needs of those who are well and those who are dependent in the community. Under the prolific leadership of Dr. Ng Wai Chong, this series of continuing professional education was started in 2022 to raise our standards of care, practice, and understanding of person-centered and holistic care, and also bring joy to the caregivers, empowering them to care for their loved ones in the community. Over the years, we have covered a wide variety of topics, and these are very important to community aged care physicians, such as end-of-life care, functional rehab, mental health, dementia, falls, Parkinson's, wound management, and caregiver support, amongst many other topics which you can find on the YouTube series based on the QR code you saw during the introduction. And this afternoon, we are eagerly looking forward to sharing by Dr. Tiah, and I will hand over the time to Dr. Ng to introduce her.
Thank you, Christina. So this afternoon, we have something really special. It's really a lecture on how do we critically read a research paper. And many of us in community services, we might have left the academia for too long a time. And so sometimes we are quite far away from evidence-based medicine. It's not that our practice are not evidence-informed, but also there are very few research papers related to our work. So today, we are very happy to have invited Dr. Tiah, who is a medical doctor with more than 15 years experience as an emergency medicine specialist in Singapore, and is passionate about teaching of evidence-based medicine for healthcare professionals. So since 2010, she has been actively engaged as a trainer at both local and regional workshops for critical appraisal skills, and is well-versed in the facilitation of EBM. So to help us understand it better, we have selected an article related to our field of work, which is home-based primary care, and a very rare randomized controlled trial on this kind of care model from New York City. So we have given you the link, and I hope all of you have read it. So Dr. Tiah will explain critical appraisal, but from time to time we'll refer to the article. So hopefully that this will facilitate our learning. So the format is like the past, 45 minutes of lecture followed by Q&A. So Dr. Tiah, please.
Yeah, thanks for the introduction. I will share my slides, yeah. Okay. So this session is about critical appraisal and some emphasis on key concepts for healthcare professionals. So what I will do is we will start with a big picture of what evidence-based practice is meant to be. And then we will also have a quick look at the salient parts of an article, which parts of article you can ignore, which parts you need to spend more time on. And then the main focus is on the next part, which is appraising the RCT with these 4 big questions, right? So we'll go straight into, okay, the big picture. So when we say evidence-based practice, it encompasses a few things, not just the research evidence. So it always starts with a clinical encounter. So when the patient meets the practitioner in whatever setting it is, hospital, home, clinics, okay, and the circumstances of the encounter. Then the second part is the patient's expectations. What would be their expectations be from the encounter itself, their preferences, their values. And then, of course, we have to have the best available data or evidence from our relevant studies in the medical literature. And last but not least, we need the practitioner to actually combine all these together, in addition to his or her own clinical practical skills, and then communicate the decision of the treatment or intervention to the patient itself. And then both of to help the patient come to an informed decision about their treatment. So this is evidence-based practice lah. So when we say evidence, right, what we refer to is the medical literature. And this usually comes from researchers who does this very cheap research methods and come up with research, and then it becomes part of the literature. And then as user of the literature, we actually look at the same pool of publications, but what we are looking at is actually what information is there in this pool that I can extract, and how relevant is it to my own patients. So as user of the literature, we are actually it's not necessary for us to actually dwell very deep into statistics stuff and all that. So this afternoon there will be a little bit of it, but not much lah. So don't be scared, okay? So it's going to be very practical. User of the literature, any practitioner can do, but not every one of us can be a researcher. But you don't need to be a researcher in order to practice evidence-based practice, right? So that's the first big point that I wanted to bring across lah. Okay, then when we actually look at the literature and then we pull out the papers to help us extract information that could be relevant to our patients, there's this framework that we use, and these 4 big questions. Is the research question of the paper clear? Can I trust the results of this study? And then if I can trust the result, then we look at the results. What are the results? What do they say? How do I interpret them? And then lastly, how can I apply this back to my own setting, to my own patients? So these 4 questions is the same for any sort of paper, scientific, at least medical paper that we come across. And there are many types. So largely, broadly speaking, we have the diagnostic papers, we have the randomized control trials, and then we have prognostic studies. And then all of these can be combined into, systematic reviews can be done for all of these. So each of these have their own set of criteria, but they have the same 4 big questions in the framework. All right. So for today, we are only going to do randomized control trials. And usually when we do this, it takes about at least half a day to finish, but we only have less than 1 hour. So some parts I will do a little bit more, some parts I will skip over. Not possible to do everything, but this session is mainly to give you a flavor of what it is to actually do, and hopefully to assure you that it is not difficult. In fact, it's quite common sense, okay? Okay, so the next part is when you pull up an article like the one that we shared before this session, and you look at it, you no need to read from the first word to the last word lah. So there are certain parts when we do critical appraisal that we focus a bit on. Okay, so this part I'm going to go quite fast. But so when we look at it, of course, first thing you look at the abstract lah. But this is a summary of the study. It's just good for screening purpose, but not enough to do practical, actual critical appraisal. But if you're just screening to look what is this about, who are they recruiting, who are they investigating, what's their outcome of interest, is good enough. Okay. And then of course the introduction, this one can totally skip lah. Don't need to know why they are doing this study. Okay. So for user of the literature, we don't have to know. So skip it totally. But just be mindful there is usually a last paragraph in this introduction section that is important. So look out for this. Sometimes they put it under a separate heading. Sometimes they merge it into introduction. But this is the aim, the hypothesis, the objective, the goal of the entire paper. So this one, you must look for it, and then it's important, okay, because it defines their research question. Okay, so later when we ask our first question, this is where we'll come to for our answer lah, okay? Then of course it's followed by methods. So the methods describe what did they do and how did they do it. So this one again important, in fact very essential. Critical appraisal, this is the part that we focus mostly on, because at the end of it, we don't have to read everything, but a lot of important information is found in this section. And it helps us to decide the results that we are going to see later, how much can we trust those results, okay? And there will usually be a part about data analysis. So this part is where the statistician's input is most important and captured. But for us, just reading to extract information, this part not important. No, don't need to, unless you are taking exams, taking exams or you want to become statistician, then you need to understand this. But largely speaking, if you're just reading to extract information for your patients that's relevant, you can skip this part. Just make sure that they write enough. If they write 2, 3, 4, 5 paragraphs, it means they have done due diligence with their statistician, or that they've done enough to assure us that some robust statistical method has been used to make sure that their findings, the results and data is properly analyzed. Okay, so I generally skip the entire section at all. So don't need to lose sleep over this, okay? There's a lot of technical terms in there that we don't need to know, all right? So skip. And then for the results, this one we have to see. But the thing about results is, if in the method section already you critically appraise in the method section and you realize there's a lot of flaws in this study, don't bother to look at the results. Don't bother to look at the table, the figure, because if the method is flawed, the numbers don't really reflect the true situation. Okay, again, don't waste time. If your methods part is already tells you something is wrong or something is not very right, or you don't trust these results, okay? But if you do trust the results, what you need to look at is some key features. Later, when we go into the questions in the framework, we'll go a little bit deeper. They're usually text, or sometimes they're tables, sometimes they're figures. And the thing we want to focus in the results, right, is on the primary outcome. Okay, if they write about secondary outcome, also don't bother. Okay, just look for the numbers that are relevant to the primary outcome. Okay. So this is some of the tables that you see in the paper later. Okay. Now, the discussion bit is what the author's point of view, their opinion about their findings and all that. It's not important. I will generally skip this part as well. Okay, and the conclusion is also not important. The reason why it's not important is because I, as a user of the literature, I have to come to my own conclusion based on the methods and then the results that I see. So I usually don't bother to look at what the authors are saying. All right. Okay. So, okay, so far, I hope. Okay. Then later, not okay, you can ask me in the Q&A session, yeah? Okay, so we go into the actual session of critically appraising an RCT. So there are 4 big questions, right? So we will use this article again. So I will extract certain parts from the article and use as examples, but we may not be able to close the loop about whether this article is applicable for your setting or not. But let's see where it goes in terms of time and where we arrive at the end of the session, yeah? So the first question is the question clear? So by question, I'm referring to the research question in the paper. Okay, so is the research question clear? And this one, some of you might have seen this framework before. It's PICO. It helps to frame our research question and also a clinical question. So P refers to patient or population of interest. It can be defined by either age, adult children, geriatric and all that, or by clinical condition, severity, stages, or subtypes. Also setting, like patient in A&E versus patient in an outpatient setting. So this is the population of interest. I is the intervention. Intervention can be drugs, quite commonly drugs, but it can also be a procedure or some invasive invasive surgery or something like that. It can also be just protocol or workflow. So for example, I think in this paper, it is a type of a workflow or different protocol, comparing 2 types of protocol, right? So that's intervention. And in RCT, we always have a control. Sorry. So the control could be the standard or usual treatment, or only just that, or it could be standard usual treatment plus a placebo, if we're talking about drugs, or it can be standard usual treatment plus a different drug. In this study, I think we are comparing the home-based primary care versus an office-based primary care. So the control is the office-based primary care. Right. Now, O is outcome, and this one we focus mainly on a primary outcome of interest. What is the main impact of this intervention? And it can be about a reduction or about a decrease or increase or decrease in event rate, like death, admission, or a certain type of measurement like height score, pain score, for example, or weight or temperature. Okay. So in this study, I think they have many primary outcome of interest. So we won't go through all, we will just take one or two as an example when we reach that part. Okay. So coming back to the paper itself, if I were to ask, is the research question clear? Where do I look for the answer? I go straight to look for the hypothesis or the aim of the paper, which can be found in the introduction section, okay, the last paragraph on page 3 in the paper list. So this is that paragraph there. So P will be homebound adults. And then intervention is the home-based primary care versus control, which is the office-based primary care. And then he has the whole list of primary outcomes that he's interested in. Okay, so is the question clear enough? So to me, it's quite clear lah. Okay, quite clear. Okay, the next part is can I trust the result? Okay, this part for RCT, there are a few, actually the most criteria compared to all the other types of studies. But there are important concepts here that I will dwell a little bit more into. Okay, so just bear with me. This part is a little bit long, okay, but broken into many, many small parts. Okay, can I trust the results now? So two main concepts that I want to introduce here. So RCT, I want to go through the key processes in an RCT just to put everybody on the same page, and also touch a bit about what it means when we say risk of bias. Okay, so in key processes in an RCT, right, we have a randomization. So randomization essentially means generating a sequence for assigning a patient to this group or that group. And then after we generate the sequence, we have to implement this sequence. So that's called allocation concealment. And then the participant will go into whichever group they are assigned. Okay. So once they're in their respective groups, the treatment or whatever will start. And then we have to, once we institute the assigned treatment or control, they have the blinding comes in. The blinding comes to play. And then while we are doing the intervention or the control bit and make sure they are blinded, we need to be mindful that all the other treatment they are giving are also the same for both groups. All right. So each of these, I'll go a little bit into detail later. So at the end of the study period, what do? We collect all the data, make sure it's complete follow-up, and then we do analysis. Okay. So in this entire process, it can be classified or broadly grouped into these 3 big questions. So at the beginning, was it a fair start? Remember, we have 2 groups and we are comparing which one is better, which one is worse. So it must start fair, okay? At the start, it must be fair. Then once they receive their respective assigned treatment or control group and they start the study, then is it a fair race? And at the end of it, is it a fair finish? Okay. And when we say fair, we are referring to this potential risk of bias in each of the key processes. Okay. So risk of bias essentially is what we also call systematic error in findings and in conclusion. And this can be introduced at any stage of your research, at the design, the implementation, even at the data analysis stage. And essentially, it is not a good thing because it leads us, it misleads us. So it deviates from the truth, either overestimate or underestimate the true effect. That's bias. And when we do critical appraisal, we always talk about risk of bias. How high is this? How low is the risk of bias? And that risk of bias essentially is the likelihood that the study results may be misleading because of the way it is conducted. Okay, so high risk of bias, that means tendency to deviate a lot from the truth. We will have lower confidence in the results that we will see. And when we have low risk of bias, it is a good thing. Low risk of bias, less deviation, and then we can have more confidence in the results that we see. Okay, so if we do critical appraisal in evidence-based practice, risk of bias is a very commonly used term, right? So for all the key, each of the 6 steps that is here in the key processes in an RCT, we have to assess for risk of bias at each stage. So it will help us decide, can I trust the results that I'm going to see later? Okay. And so we just start with the first one. So randomization, we hear this term quite often. So just revision for many of you probably. So it just means generating a sequence of assignment and assigning people to intervention or to control group. And it has to be entirely by chance, Each eligible participant will have equal chance, 50-50, of being assigned to both groups. 50-50 chance. So that's true randomization. Okay. The whole purpose of it is if we do this well enough, we are trying to balance the prognostic factors in both groups so that any difference in the outcome, we can say that it's because of the difference. One got intervention, one got no intervention. So the next one, these are the methods of randomization. Throw a dice, flip a coin, or you can use the random table or computer generated nowadays. Okay, so these are different methods. Right. So for the paper itself, this is one of the first criteria. So you go to page 4 and you look under randomization and look how did they describe it? So what I'm looking for is essentially something to tell me they did randomization. So they did it by computer generated randomization in blocks of 6. So this block randomization is another story on its own. Don't have time to go through today. But what I'm looking for is they say they randomize. And how did they randomize? Okay, so that's good enough for me. So tick for this one. Okay, well done. So that's the first criteria. Second criteria, allocation concealment. So it means whatever sequence I've generated, it is kept hidden or masked. And nobody knows. So the upcoming assignment of a participant to any of the group remains unpredictable before and until the assignment occurs. So before it reaches the patient, until it reaches. So nobody knows what is it. Okay. So why is this important? Essentially, we can introduce bias if we know what is the upcoming assignment. And the recruiter can choose if they know that the next eligible patient is meant to go to one group. It can somehow persuade the patient not to participate or reject the participant. So in this way, what it is doing is actually interfering with the randomization process. So you can potentially group people with better prognosis into one group and poorer prognosis into the other group, or vice versa. Okay, so there is some manipulation in some ways. So not good. Okay, not good. When we don't do this well enough, the entire randomization process is compromised. Now the eligible patient doesn't have an equal chance. There's an added component of the recruiter trying to influence where it goes. Then the prognostic factor may not be as balanced as we wish it to be. And when it's not balanced, then whatever difference we see cannot be attributed to the intervention alone. Okay. So for the paper on page 4, in the same paragraph as the randomization that we were looking for randomization, they actually have, I'm looking for the word allocation concealment. So many randomized paper will write it, but if you don't see it, just read carefully again. So just look at this part that they say the manager informed participant of their assignment by phone. and both were unblinded. So the word unblinded is used here, but here the unblinded actually means allocation. It refers to no allocation consumed. Okay, because the project manager knew about the sequence, the assignment, and then they informed the participant about it by phone. Okay, so in that sense, don't have allocation consumed, so we cross it. This one fail. Okay, this criteria fail. All right. Now, if the randomization is done properly, baseline characteristics will be similar or comparable, at least comparable between the two groups. So we do want this to be as similar as possible. When the characteristics are not balanced for whatever reason, right, or some very great difference in both groups, it can be explained by either systematic error like bias or by chance. Okay. So systematic error essentially is a consistent deviation. It is a problem with the people doing the research, and it can and should be prevented. But random error, chance, is not an issue with the people doing it. It's just chance. Okay, it's just chance. It can be minimized, but it cannot be prevented. Okay, but these two errors can give rise to the difference in baseline characteristics, right? If we do our randomization and allocation consumption well enough, we can eliminate systematic bias at this stage. Then any difference that we see is all due to chance. Okay? Can So when we look at this, we look for table 1. Most RCT will have a table 1, and they will have a whole list of characteristics of the patient. So essentially what we need to do is just to compare the two groups, the intervention group and the control group. Just look at the numbers. So I'm just taking a snippet of this and just looking at this age more than 85 in one group versus another group. So this is essentially what you need to pick up, is just eyeballing the numbers and then have a sense of will this difference put one group already at a disadvantage at the start. Okay, so for example, if this intervention group has more people with age more than 85, it's already at a disadvantage to this group. Okay, so if my results at the end of it show that this group does poorly with the intervention, I'm not sure whether it is because of this age difference or not. Okay, so you have to keep that in mind. So you can go through that list of characteristics and just see which one is difference, and then whether it will affect the difference in result that you will see later. For this table, don't bother to look at the p-value. No, don't bother. It's sometimes there, sometimes not there. It is okay to be not there, because I don't need the p-value to tell me whether these numbers are significantly different. I mean, I don't need to know significantly different or not at this point. I just need to eyeball the number. My whole point is whether this group will be disadvantaged enough by that difference or not. Okay. So this one, it has to be up to, I put all 3 answers here, whether, because it's up to the expert, your own expertise in terms of this field. Look at the list of criteria, which one, if it's very different, it makes a difference. Like some things may not make a difference to the outcome that you are interested in. Some things may not. So so it's actually it's up to an individual. There's no right or wrong answer in a way, and it's up to your own threshold as well. Okay, so it could be at the end of the day, are the baseline characteristics similar, largely similar enough? It is a very subjective sort of decision. Okay. Okay, now we come to the raise part. So the patients have been assigned their treatment, and then now they have started the research, started collecting data on it. So blinding is the next one. So blinding is quite not difficult to understand. Essentially is to keep everybody unaware of the assignment until you implement, while you are implementing the thing. So everybody means participant, healthcare provider, people who collect data, and the outcome assessors. Nobody knows what the patient is receiving. Okay, and when blinding is not done properly or inadequate, it can affect how people respond, the behavior, affect our assessments, and even our analysis. And that introduces systematic error, and that's going to deviate your result. There are times where blinding is not possible, or either not feasible or not ethical. So these are some examples lah. Okay. Okay, so these are some examples where it's not possible to blind if you're comparing these two. No? So when it is not possible, you have to consider, the next thing you have to consider, right, is about the outcome. Whether this is an objective outcome or not. Objective outcome are less susceptible to bias. Objective means like death or no death. Subjective outcomes are more susceptible. So subjective outcomes are like pain score, satisfaction score, and interpretation of radiological images. So these are more susceptible to systematic bias. Okay. So we look at the blinding. Again, it is the same paragraph on page 4. Okay. Did they do blinding? Got lah. This one quite clearly they write everybody blinded. Okay. So this one clearly passed. Okay. Can It's okay, we are halfway through already. Okay. So then the equal management. Okay, so this one again, not a difficult concept. Everything stay the same for everybody except the difference in the intervention. Then if I see a difference, I can attribute it to that intervention. Okay. So for this particular paper, did they have equal management? So I'm just pulling out here, also on page 3, this particular paragraph. And I look at this thing that says, even for those that are assigned to the intervention group, they are advised to continue their usual care or standard care, which is the office-based care, until their first visit. Okay. So I look at this and I interpreted it as, okay, they largely have similar sort of a management. Everybody office care until their first visit for the intervention care. That's my interpretation. Okay, so I will pass this one. I'll pass this one. Okay. So the next part is the finish. Is this a fair finish now? So by fair finish, I'm looking at 2 things. The first one is a complete follow-up. Complete follow-up means everybody remain in the study at the end, until the end. Okay, remain in the study until the end. This is important because if they stay until the end, I have the outcome data for everybody. And that's important. Okay. So complete follow-up. If my study starts, I have this amount of people. At the end of my study, same amount of people, and I can easily count my outcome. Let's say it's mortality. Okay, so this particular study done mortality like this. So 10% in intervention group, 20% in control group. So it clearly favors intervention. Okay, but what if I have some loss to follow up? So let's say I lose 10%, 1% from each group. I lose 10%. So I started with 10 people, I end up with 9 people. Okay. Or similarly, I had 10 people, I had 9 people. And then the one that got lost to follow up actually died somewhere outside, which I don't know. I don't have their data. Okay. So all the data that I have are the remaining patients, and my data shows 10% mortality in both groups. So my conclusion is there's no difference. Okay, so that's how missing data can actually mislead us, right? So for missing data, it can potentially affect the intervention effect with misleading conclusion when these few criteria. So when the proportion of participant with loss of follow-up is more than 20%, this is the first, this is the easiest way to actually have a sense of, is it too much loss to follow-up? Okay, but there are many other more complicated way. But if this is the first time you are hearing this, just start with the 20% as a baseline first. Okay. And the other thing is about event rate. Event rate is low. Imagine what event rate means, for example, in this case, if we're talking about mortality, death, if the number of death is low, and then you are missing one person who has that event, then it clearly will skew your conclusion. Okay. Then there's this thing called sensitivity analysis that can manage this missing data thingy. So we don't have time to go into that. But if you see a word in any of the RCT, it means it's trying to manage the missing data that they have. Okay. So coming back to the study itself, Proportion with missing data, where can we best find it now? So a shortcut, I'll go straight to this figure 1 on page 14. Then you look at a few of the numbers. So the one in green are the randomized one. You realize one in green randomized. But what denominator we are looking for is actually the one in red. Who are those that are actually included in the analysis? So my denominator is in the red box, okay? Proportion, I need numerator and I need denominator, right? So my denominator is the one in the red box, okay? So missing data, how to find it? Okay, so for the study, it's a little bit complex because I think they terminate it early, but no worries. Although they terminate early, but in terms of data analysis, they say please take everybody at 12 months as the end time. So we assume study ends at 12 months. Okay, so how many reach the 12-month period? So one group 78 out of the 114, the other group 88 out of the 12. So we just do simple maths lah. So if 78 reaches the end, how many didn't reach the end, right? Okay, so you just minus, it becomes 36. So 36 out of 114, you get 32%. And the other arm, we have 24 out of 12, 112, we have 21%. So just eyeballing like that, I'm going to fail this criteria already, okay, just without doing anything else. It's a little bit too much. So whatever results I see later, I don't know how much of it is affected by this missing data. Okay. Okay, intention to treat, this is the last criteria for this question. So intention to treat, it means analyzed in originally randomized group. Okay, regardless of whether you change protocol, whether you lost to follow up, etc., etc. Okay, and this is important because it balances it helps to preserve what the randomization process is trying to do. That means trying to balance both groups. So we do intention to treat analysis to maintain or to keep this balance. And it is also a good reflection of the real world effect of the intervention. Because in the real world, there will be people who are lost to follow up. Okay, there will be people who didn't turn up for whatever reason. Okay, so it is a conservative estimate. Okay, this is intention to treat analysis is a conservative estimate, right? So for the paper, for this thing, we have to go a little bit into, sometimes they put it under data analysis, sometimes they put it somewhere else. But you can just look for this word, intention to treat analysis. So on page 5 in this paragraph, they actually mentioned that there's an intention to treat principle here. So usually like that, they say I will pass them. Okay, they say I'll pass them. But one other way, if you are a little bit skeptical and you want to double check, is you can go and look at this diagram again, the same figure 1 on page 14, and similarly look at these two boxes. By right, randomized numbers, the green number, the number in the green box and the number in the red box should be the same. Okay, should be the same. Okay, so in this case, it's slightly different. It's slightly different. Yet they say it's intention to treat. So this one, I dig a little bit deeper. Okay, and you realize that they excluded the people who withdraw from the study. Okay, so strictly speaking, if somebody withdraws from the study, we cannot ethically include their numbers in the thing. Okay, so this one, I would still say they are doing intention to treat analysis because they included the rest, people who died before 12 months, who are lost to follow up, who dropped out and things like that. No? And even if you randomize to this arm, but you did not receive for whatever reason, they still included them in. They only took out the people who withdraw. Okay, so I still give it to them. I still give it to them. So I give them double tick for this one. Okay, can pass. Okay, so at the end of the day, we have something like this. So usually we just check it on the side. So it's a mix, like it's not clearly all tick, green or tick, and it's not clearly all red, right? So this one you have to decide. If it's clearly all red or majority very red crosses, right, or everything failed, then you can stop here. Then we all close shop and then you can go drink kopi and enjoy the rest of the Saturday. But unfortunately, it has a little bit of green. Okay, we go a little bit more into the results for now. Okay. But this is the approach that we actually encourage in evidence-based practice. When we pick up a piece of paper, don't go straight to the numbers. go to the methodology first. Because if the methodology is rubbish, the numbers don't mean anything. Okay, don't waste your time trying to figure out this minus is what, this table is what, okay? You know? Okay, so we come to the results. So this is another, a little bit of a section, heavy section here. Just stay with me for a little while more. Huh? Okay, so again, a few important concepts. What is intervention effect and what is clinical importance, what is statistical importance, and a bit about magnitude of the effect, where I will bring the results from the paper in for some examples, okay? So when we say intervention effect, essentially it just means the difference in the outcome data for the two groups, 2 or 3 or 4 groups, depending on your study. So intervention effect is purely simply just difference in outcome data. Okay, so outcome variables in all the RCTs itself, we have many. So if we have a continuous variable like height, weight, temperature, length, and things like that, then we're talking about differences in mean. Oh, sorry. It went too fast. Okay, so if we have differences in effect, in differences in mean, differences in median for continuous, for dichotomous, discrete, okay, numbers. And then the effect, we usually present it as risk ratio, odds ratio, absolute or relative risk reduction. Okay, we don't have time to go through all of this, so later we'll just pick some to illustrate. So continuous, dichotomous, and there's a third one that is a time to event variable, and this is incorporating time into the results itself, like hazard ratio, median survival. More commonly, in oncology paper, you have a lot of these presentation of results in this manner. Okay, I want to talk about point estimate. So we have this different measure, and then they are always presented as a point estimate and an interval estimate. Okay. So point estimate is a single value, one number, okay, that represents a summary and the most likely effect of the intervention. So it gives the magnitude. The interval is a range of possible values because we are collecting samples. When we collect samples, it may not be the true representative of the reality. So these are the range, okay? And that affects the precision of the intervention effect, okay? So the important questions to address here is not what is the point estimate, what is the interval, but two things that we want to say, is this of clinical importance, and then is this of statistical significance? Okay. So clinical importance, for clinical importance, I just want to briefly do so. When we look at this example, these 3 examples here, death between 2 groups, cystitis, incidence between 2 groups, osteoporotic fractures, proportion between the 2 groups. All of them, absolute risk difference is 2%. Which one of these is of clinical importance? Okay. So it depends on the outcome itself. So if it is a catastrophic outcome, like death, small difference could be considered important. If it's a not so catastrophic events, like maybe skin itchiness or maybe cystitis, so that absolute difference in risk needs to be bigger. Okay, so this one is very, very of a clinical, need your own clinical judgment. And my threshold and your threshold might not be the same. Okay, might not be the same. Again, no model answer, but the general principle is whether this is a catastrophic outcome or not. And we always need to think about clinical importance, right? So another type of example, this blood pressure, difference in systolic blood pressure, difference in pain score, difference in weight, okay? And again, we need our clinical judgment. How much is meaningful in practice? Okay, meaningful in practice means a difference that is clinically impactful. And then how much of it is meaningful for the patients? How much of it is meaningful for the patients? That means a difference that's relevant for the patient. This is where the patient's values and patient's preference comes in. okay? So we just can't go by numbers alone. There's no above X amount is clinically important, above X amount, below is not, okay? It depends on your patient, it depends on your clinical expertise. And there's no magic number, no magic number. Clinical importance is a totally clinical judgment by yourself, okay? And no two people may not have the same number, they may have a similar range, right? Statistical importance, okay, this bit is a little bit about statistic lah. But all we want to know is there statistical importance or not? So probability value, we're talking about p-value here lah. Okay, it just means how we see something that is different, how much is it due to chance? So we know that p-value close to 0 is unlikely due to chance. That means it's real, likely to be real. If you're closer to 1, it's more likely due to chance, so may not be a real difference, okay? So people usually set the threshold at 5% or 0.05, very commonly seen, okay? But it is not, it can totally shift according to the researcher. It can be 0.01, it can be 0.1 entirely. But it's just a number that's arbitrary. That's one number. Interval estimate. 95% confidence interval is the commonly reported one, but you can have 90% confidence interval, okay? It just gives you a range of estimate that the true value may be within this range. If we are talking about a difference, no difference is 0 ma, right? Difference, one group minus another group 0. So anything, if the interval captures the number 0, this result is not statistically significant. If we are talking about a relative difference usually refer to ratios, okay? And a ratio of 1, there's no difference between the numerator and denominator. Huh? So if the interval includes the value 1, it means it's statistically not significant finding, okay? So we always emphasize in evidence-based practice, statistically significant difference is never the whole picture. Okay, never the whole picture. Let me show you an example. So if we just look at p-value, right? The way to look at this is the top here, there is a statistically significant and statistically not significant, clinically important, clinically not important. So these two value, a difference in weight between the two groups of 5 kilogram. 5 kilogram may not be statistically significant, may not be statistically significant, but can be clinically important. Then similarly, a difference in weight between two groups of 2 kilogram between the two can be statistically significant, no? Can be, but it may not be clinically important, okay? If we look at a continuous variable like pain score, similarly, the number, it can be not statistically significant, but clinically important, and vice versa. Okay? So this is an interval. So statistically significant interval, if this is a difference, absolute difference, if you capture the number 0, it means it's statistically not significant. In this example, the 0 is not there, although it's very close lah. There is 1, the lowest is 1, but they say this is statistically significant because it didn't include 0 in that range, right? So in this other example, 0 is included in this range, so this result is statistically not significant. Okay. But the trend seems to favor, a lot more is falling on the intervention side. And this is something you cannot see in p-value, the trend, okay? Confidence interval you can. So nowadays, a lot more papers are reporting just confidence interval and not so much p-values. Sometimes they give you both, but more information can be gotten from confidence interval. It may not be statistically significant, but we can tell the trend. Okay, and that's an important information too. Okay, so magnitude of effect. So this is where I'll bring in a little bit of the paper. So I'm just going to just go to page 7 where this paragraph is. This is just about quality of life. And it does says the mean difference between the two groups is 1.76 with the 95% confidence, etc., etc. So I mean, for somebody like me who doesn't deal a lot with this quality of life, I mean, 1.76, I don't know clinically important or not important. Okay, then on page 4, I think they explain a little bit about this quality of life thing. So I'm just looking at this and okay, now I understand a little bit. The range, a range could be 13 to 52. That's the range. So if your range at about 30 something is within this, somewhere in the midpoint, not too high, not too low, no? But they also say a change in score of more than 3.9 is considered a minimally clinical important difference. So this one is good. I don't have that clinical expertise, but on the paper, in the paper, they tell me what is clinically important. I mean, I don't know based on your experience whether this is something you agree with. Okay, so if it is not, it's okay. You can have your own threshold. Okay, you can have your own threshold. But I'm just going to use this. So if more than 3.9 is going to be clinically important, right? Then I look at this 1.76. 1.76 not clinically important, but statistically is significant, statistically significant. But essentially, it means to me, this result is nothing to shout about, okay? Nothing to shout about, okay? So if I compare, I need to compare these two, okay? So for the home-based patients, the difference between, so within the home-based group, there's a difference between baseline and at 12 months. So just within this group, clinically, is it important or not? No, is it important or not? Yeah. Okay, so this is this number 1.76 . So yes or no, it's up to you to decide. Also, if for me, I would say it's not clinically important because they say more than 3.9 the difference. Okay, so not important. But statistically significant, yes, the result shows statistically. Okay, number 1 is mean difference. So the confidence interval includes 0. I mean, confirmed by the p-value. Okay. Okay. Then the other thing they also mentioned the difference in quality of life measurement between the two groups. Okay, between the two groups. Again, what was the number? 1.25. Again, less than 3.7, 3.9, less than 3.9. So clinically, not important. Statistically important or not? Statistically also not significant because it includes the number 0 in the confidence interval. Okay, and the p-value also confirms that. So not important, not important. Okay, right. So that is the quality of life. So I won't go through the other two continuous measurement, but I want to touch a little bit about this discrete measurement, which is numbers of hospitalization and ED visits. So on the same page 7, they have this paragraph, and they mention that fewer intervention patients experience hospitalization. So seems to favor intervention group. So I just want to pull this out and correlate it with the table you see on page 19, which is in table 3. This is where they pull the number out from. A little bit of this is just purely hospitalization. And when they say within group difference, this 35.4 refers to here, within group at baseline and at 12 months. Okay. Similarly, for the control group, within group 17.5 refers to control group at baseline versus control group at 12 months. Okay. And then you have the between group difference. That is the difference between these two. This. Okay. So that's how you get 17.9. The reason why there is a minus, the reason why there is a minus is because traditionally we always use intervention number minus control number. Okay, intervention number minus control number. Okay. So in the intervention, in this within group, intervention, I mean the later one, that means the 12 months minus the baseline. Okay, that's how you end up with a negative number here. Okay, but don't worry too much about this. If we translate it to English, it's actually quite logical. Okay, so for now, just look at the numbers, ignore the minus plus sign. Okay, ignore it. Okay, I want to go a little bit about this because they mentioned the term number needed to treat. I don't know whether you see on this page, this number needed to treat is 6. So just wanted to touch, this is one of the other important concept. I think this is the last part already lah, okay? Just, I hope you are still awake. This is the number needed to treat. So I'm using the numbers from the paper. Okay, again, just to illustrate it here. So this 35.4 and the 17.5 is plucked from the paper. I just remove the minus sign to actually make it less confusing. So if I take this two, oh, sorry, I should include the minus sign in the 35 and the 17. Okay. Anyway, if we take these two as extracted from the table, the absolute difference is a minus 17.9, okay, in favor of the intervention. Then we thought, how did they come up with this number that we need to treat? And then what does this number mean? Okay. So I'm going to use another example to illustrate this number needed to treat. Then I'll come back to this page again. Okay. So this is a hypothetical study, new intervention for people with AMI. New intervention versus current treatment control, reducing mortality. Okay, that's the clinical question. So I have I have current treatment here. Okay, on this arm, the green means this is like 100 patients, 100 squares. Each square is one patient. 100 squares, 100 patients in each arm. The green ones are the people who survive with the current treatment, and the red ones are the people who passed, who died in the respective groups. Okay, so mortality with current treatment is 40%, and then with the new treatment is 20%. That's the risk of mortality. Okay, and if instead of current treatment, I use the new treatment for this group of patients, that means if I treat 100 patients with the new treatment, I could make a difference in this group, right? Can you understand this part? I will make a difference in this group, okay? And this group is 20 patients. So these 20 patients, if I had used the control, the current treatment, these 20 patients would have died. But because I use a new treatment, they survive, okay? So if I treat 100 patients with a new treatment, I can prevent death in 20 additional patients, right? Okay, and how many patients do I need to treat in order to prevent one additional death, or prevent death in one additional patient? So this is like a maths, okay, maths type of thing. Okay, so I treat 5 patients in order to prevent death in one additional patient, and that is what we call number needed to treat. Number needed to treat equals to 5. It means we need to treat 5 patients with new treatment in order to prevent death in one additional patient. That's number needed to treat. Okay. Now, there's a relationship between number needed to treat and absolute risk reduction or absolute difference. There's a relationship. Okay, what I've shown you earlier is a diagrammatic rationale for this number needed to treat. But you can directly mathematically calculate number needed to treat from absolute difference. And this is how, okay? So if you just minus this to mortality, 40 minus 20, it gives you 20% difference, okay? 20% difference. And the formula is this, 1 divided by absolute risk reduction or absolute difference. 1 if it's a decimal, and if you are going to use percentage is 100%. So it translates to this. Okay, that's how you get 5. Okay, so this is mathematical. Previously, I showed you the diagram, the rationale behind how we come up to this number needed to treat, and why we say it as we need to treat 5 people in order to prevent one death in one additional patient. Okay, so NNT is 5, and this means that for every 5 patients we treat with the new treatment, we can prevent death in one additional. Okay, so this is NNT. Now we come back to our HBPC. So if the absolute difference or the ARR is 17.9%, What is the NNT? So we apply the same formula as previously. We get 5.6. All right. And then that's how the number is rounded up to 6. Okay, so NNT is 6. It means that for every 6 patients that we treat with HBPC, we can prevent one hospitalization for 1 additional patient. Good or not? Good. The other thing about NNT is number bigger better or number smaller better. Okay, just think about it. If my NNT is, okay, let me look at the confidence interval. So NNT is 6, but 95% confidence interval ranges from 3 to 100. That means that reality, in truth, the NNT could be anything from 3 to 100. Okay, if the truth is 100, it means NNT equals 100 means I need to treat every 100 patient. But for every 100 patient I treat with the HBPC, for every 100 patient I treat with that, I can prevent hospitalization in 1 patient. Okay. If the reality is 3, okay, if the real number is 3, if NNT equals to 3, for every 3 patients that I treat with HBPC, I prevent hospitalization in 1 patient. So I treat 100, I prevent 1. I treat 3, I prevent 1. NNT higher better or lower better? No? The lower the NNT is, the more impressive the result. Okay? That's the general principle of NNT. There are a few more things to it, but don't need to know about that now. Okay? Just remember that if this is the first time you hear about NNT, this is what is it in essence. All right? Okay, so that's the main concept for now. So the last part about applying result, this one I will refer to Dr. Wai Chong to talk about. But essentially, now that you know the score, the quality of life score is like this, the hospitalization, how many patients you can prevent hospitalization if you use HBPC. How can you actually apply this to the patient in your respective settings that you are in? Okay, so these usually depend on whether your patient profile is similar to the study patient profile. It depends on whether your setting has the means to do the HBPC as the study has done it. That means they have, I think, quite a multidisciplinary team and quite a regular number of visits. Okay, whether we have the capacity to do the same one or not. Okay, to get the same result, you need to do the same intervention. Okay, and of course, whether you have the resources, the money, the equipment, the manpower, everything to do all this. So this is in the how can I actually apply this result to my setting. You can have a very, very impressive result with a very, very robust methodology. But if in your setting is limited by some of these things, right, you may not be able to implement it. Okay, okay, I think that's all. That's all for now. Didn't take too long, so
Thank you very much, Tiah Ling. It's really wonderful that you actually shared this. I was reading it for the first time. I didn't analyze it so deeply like you did, and it's very interesting. Actually, I did try RCT for home-based primary care and daycare centers and so on, but it was really, really difficult to do. I wonder whether you can comment on this. The waiting time for the first home-based primary care visit was very long. The average was about 56 days, I think, 1 to 2 months. And then in the introduction, they even say that sometimes the waiting time can be a few months. And yet the intention to treat started once you're randomized into home-based primary care. And then while waiting for the doctor to do the first visit, a lot of things can happen while you receive your usual office-based primary care. So, so how does this affect the conclusion? Like, for example, what I think is, if I could improve my accessibility or my responsiveness to home-based primary care, would the result be better, right? But then this RCT doesn't quite show.
Yeah.
So yeah, that's a problem with protocol-based intervention rather than drugs or procedure, because the protocol depends on your resources and so on. So yeah, any thoughts about this?
I think the it adds some complexity to this entire interpretation, and I think that's the reason why the study ended early, because of
Yes.
increased death that they are seeing in one arm, and that is the arm in the intervention arm.
While waiting for home care, right? Then
Yeah,
they
correct.
die. Yeah,
So actually, you randomize into this group, but you haven't received, maybe the reason you are dying is because you have not received that home care.
yeah,
We don't know. That's why I think, the reason they stop is purely maybe because to investigate this a little bit further.
yeah,
From a reader's point of view, what we can do is, if we are familiar with the setting and the context, we can hypothesize certain reason for this result that we are seeing.
yeah,
And whether, how does that affect how you would implement the protocol if you want to apply it to your patient.
yeah.
Yeah.
So I suppose the study did show that home-based primary care improved hospitalizations, but the other outcomes are not conclusive, right?
Yeah.
Yeah.
Correct. Right.
Then there's also something that I heard about before, something called the regression to the mean, when about the hospitalization
Ask me
rate.
to explain that.
Because like if you before the patient admit into the home care, they have got a lot of hospitalization. Then after they admit to the home care, even without doing anything, the hospitalization rate will come down. So it did appear in this study, right? The both intervention and the control had experience of reduction in hospitalization rate just by itself. But it's just that the one with home care seems to improve better. So that's why the RCT is valuable. Otherwise, you compare before and after, then it's not very conclusive.
Yes, correct.
Yeah.
So it is when we look at the tables, actually it's a little bit complex in a sense.
Yes.
It's a bit complex. And this one really requires not just the clinical expertise, but also some understanding, because there's, in terms of the sample size, although it's 140, 112, but I think it also matters when you come down to the actual outcomes and all that. There are certain numbers, they are not the same, the denominator
Yes.
is not the same. Yeah.
Yeah.
Yeah, correct. But I think so that's the thing with evidence-based practice and looking at any article that you picked up to read.
Yeah.
There will be a part that is a little bit technical. Technical means
Yeah.
what I was doing. I was just looking at the framework, and I'm asking
Yeah.
questions, looking at criteria. Then there will be a part where it really requires your experience from the setting to actually make sense of the entire.
Yes.
Yeah.
Yes.
So that's why in my very, very first slide, when we say evidence-based practice, right, the person at the core of this, right, is the practitioner.
Yes.
So with the clinical experience that you are already having, right, if you can strengthen the technique, the technical part of things,
Yeah.
actually adds a lot of value to the entire evidence-based practice.
Yeah.
Correct.
So
Because the research is only one part, one
yes.
corner of the thing only.
Yeah.
The phase is just one corner of it only. Yeah.
So from your perspective as somebody relatively objective, because you don't do home care like we do, what is your, I mean, what can you say about home-based primary care based on this study alone?
When I look at it, then the first thing that come to my mind is all these other interventions that's going on currently, all this hospital at home stuff that's going on.
MIC and so on. Yeah.
Correct. So just thinking about it logically, in terms of patient outcome, obviously there's going to be improvement in patient outcome. Obviously there's going to be. If you bring healthcare services into patients' home and do it in their setting, the amount is going to, the value add is going to improve. The question is whether the amount of resources put in is going to make that think worthwhile or not lah. So this one again is beyond me.
Yeah, it's cost effectiveness study
Yeah,
already.
yeah, exactly.
Yeah,
But I think that's what a policymaker would be most, that's crucial to their decision making lah. I put in
yeah,
X amount of money, and then how many patients, can I save?
yeah.
Or hospitalization can I save that
The,
kind of.
the other thing I felt was also surprising for me is that the quality of life is not much different between the home care and the office-based primary care. So for us, visiting doctors and nurses, we thought it would make a big difference to the quality of life, but actually it did not quite make a big difference. The only
Yeah.
difference we made is to save the taxpayers' money.
I don't know, is it because they are already at a fairly,
Advanced stage in
yeah,
their
correct.
disability.
That could be, that could be why, yeah, already in that advanced stage, so that a little bit more of how much more can you make in terms of quality of life?
My gut feeling is that doctors and nurses don't make a huge difference to caregivers. It is actually the physical caregiving help, home personal care, things that really relieve I suppose many of the respondent to the QOL questions, especially those with AD, 73% got Alzheimer's disease, dementia. So most probably the respondents are the caregivers. So doctors and nurses are, of course, very helpful, but the quality of life is really not dependent on them.
Yeah.
So it sort of
Yeah, it's
make
true.
us humble a little bit. We didn't make a big difference to our quality of life. We just make a big difference to the overall sustainability of the healthcare system.
Yeah, that's
Yeah.
true.
So we don't have any questions from the audience. Actually, we have quite a lot of distinguished friends and colleagues in the audience, in home care, in the other agencies. Actually, Christina, what are your thoughts on this particular lecture?
I think it's useful for us to understand how to read such research papers, and it's also very rare for us to have actual studies on the effect and the interventions in primary care. Usually primary care is quite neglected. So
Yeah.
I'm glad that we are taking a step in the right direction to also have more evidence base in terms of what we are focusing on. Yeah. So thanks for spending your time and your expertise to share with us. And we're looking forward also to another sharing session, hopefully, about the work that you're doing
Oh,
from
yeah, in
Dr. Tiah.
Thailand.
Yes.
Whether we can have a CME on this, clinical care in low resource areas. I think that would be very interesting. Um, I'm actually, I don't know whether Wilson told you, we are also doing something in Nepal.
Yeah, he has mentioned.
Yeah, and also in home care. Singapore, of course, is a very high resource country, but in some areas, we do see a lot of vulnerable population in the rental flats, and also in some people live in landed properties, but they are really, really asset rich and cash poor. So we do deal with a lot of social vulnerability. Maybe one day you could also share with us on your experience in these places.
Yeah. I
Yeah.
mean, the home care base here in this setting in Mesot is even more challenging. I mean, challenging in different ways lah. Yeah,
Yeah.
but they are exploring home care here, even with the limited resources that they have.
Your colleagues come to this webinar, right, in Thailand?
I'm not sure.
Yeah, our YouTube video are very good. There are a lot of for the last 2.5 years, nearly 3 years already, a lot of topics. They may want to tune in and listen. Yeah. So I'll send you the link later.
Yeah.
Anyway, got 2 questions. Wait, okay. There's one called time and cost reduction for caregivers in home base is an improvement in life quality tool. And then could post randomization factors like loss to follow-up create new confounding. Yeah, I wonder whether you can address these questions.
There are questions, not statements.
The first one is a statement.
I agree with the statement.
Yeah. The second one is a question. Post randomization factors like loss of follow-up, like especially for the home-based primary care wing, quite a lot of them while waiting for the doctor to come in already died or something happened. Does it create confounding?
Yeah. Definitely. So I mean, if we understand confounding to mean, I mean, there's some very pure definition of confounding, but in a more simpler understanding is if we understand it to mean a variable that comes in and essentially mislead us to thinking that the intervention is the one doing the result, causing the result lah. So it's some smoke bomb essentially lah. So anything that is so lots things like post randomization is anything that happened along. Remember the key processes, right?
Yeah.
Randomization and allocation consumer is just at the beginning, you know.
Yeah.
After that, you have blinding, equal treatment, and then the follow-up and the analysis part. Any of these stage can be a smoke bomb lah. I mean, they can do it well, you throw it in, you can confound the effect.
Okay.
Definitely. And that's how, I mean, prevention is always the best, but sometimes you cannot prevent. And
Yeah.
then people might do some, we don't call it manipulation of the data, but more of a computation, additional to try and address some of these. Like all the symptom, the linear regression stuff, you know,
Yeah.
trying to level some playing fields.
Yeah.
That you take away all these additional effect that other things might have, and then you still leave it to the intervention and the control thing.
Yeah. So I think with that we should end now. We are a little bit overshot, but it's been really great and very educational. Thank you, Dr. Tiah Ling, for spending your afternoon with us.
Welcome. Thank you for having me.
Thank you. All the best in your work. And hope to see you soon in person.
Thank you.
Thank you.
Thank you.
Bye-bye.
Bye-bye.
Bye.
Bye-bye.
Take care. Bye-bye.
Bye-bye.